Good morning and welcome to our fourth annual Cardiovascular Health Policy Summit. We're coming to you live from a production studio in Washington, D.C. I'm Ryan Gooch, Executive Director of the Partnership to Advance Cardiovascular Health. First, I want to thank our co-hosts, the Alliance for Patient Access and the Institute for Patient Access, for helping us develop today's program. I also want to thank our generous sponsors who have made today's program possible: Amarin, Amgen, Bristol-Myers Squibb, Pfizer, Esperion, and Janssen. I'm grateful to have Jasmine Patel here to co-host the summit with me today. And we are also joined by Amanda Conchafter and Lindsay Vadee-Nix from the Alliance for Patient Access to help moderate today's panel discussions.
Our speakers today are cardiovascular clinicians, advocacy leaders, policy experts, and patients who are joining us virtually from all across the United States. You'll notice on the live stream page you're currently viewing, there are two boxes, one for question and answer and the other for chat. Please engage with each other in the chat box. And in the Q&A box, you can ask our panelists questions during any time, and we will do our very best to answer them. If you're on social media, please join the conversation around this summit by using the hashtag CVSummit21.
Now, it's my pleasure to introduce someone who frankly needs no introduction at this point, Dr. Dharmesh Patel, for opening remarks. Dr. Patel is the president of the board for the Partnership to Advance Cardiovascular Health, and he is joining us today from Memphis, Tennessee. Dr. Patel, welcome.
Good morning, everybody, and good morning, Ryan, to the Patch team. I am Dharmesh Patel, a cardiologist practicing in South Haven, Mississippi, and the president of the Partnership to Advance Cardiovascular Health. It's my pleasure to join you once again for the annual Cardiovascular Health Policy Summit. Thank you for being with us. I am excited for today's program. Since we met last in 2020, things have certainly changed. Yes, there have been changes we've all followed in the news headlines. COVID. Rates spiked, then finally and mercifully declined. Government and industry collaborated to develop and roll out vaccines on a record timeline. Schools resumed in-person learning. Surviving businesses opened their doors again, and office workers began going back to the office once more. But the change I'm thinking of is more fundamental. We've changed, you and I. We see things differently now. Our jobs, our relationships, our life choices, our time, and our health, most definitely our health. The pandemic has, on an unprecedented scale, forced us to reckon with age-old questions of life and health and death. We are reminded that time is short. And we realize for the first time what the government and health plans are really capable of when they are motivated, when the stakes are high, when public health is at risk, and when the people demand it. The pandemic has also changed us in another important way. It has made us impatient, in the best possible sense of the word. Our patience with half measures, lip service, empty promises, passing the buck. Our patience has worn thin. There is, I feel, a raw energy now driving those of us who demand policy change. We didn't survive the pandemic, just return to status quo. We emerged ready to fight for something better. So I ask you today, where better to apply this renewed sense of urgency than to the policies that shape cardiovascular health? Think on it. The heart is, quite literally, the organ that begins and ends our lives. From the moment an expectant mother hears the sound of an unborn infant's heart beat on the Doppler, to the moment the heart slows to a stop to signal the end of life well lived. The heart is central to who we are and how we live. And those gathered today want to preserve as much time between those two moments as possible. We want policies that ensure that the heart and the human being it animates enjoys the best possible health every second, every beat. And quite simply, we aren't willing to wait any longer. So here we are today, united in our resolve and ready to chart a course forward, to pinpoint the hurdles we face and the solutions we can champion. We'll explore several topics that demand action. We'll talk about non-medical switching, which is the growing problem of health insurance companies changing the stable patients' prescribed medications just to maximize profits. We'll talk about reforms to Medicare Part D, where issues of coverage and out-of-pocket costs have plagued heart patients far too long. We'll explore the topic of medical guidelines, why uptake lags for years sometimes, and how speedy implementation can make life better and safer for patients now. And we'll discuss peripheral artery disease, where a severe lack of awareness compounds racial inequities to leave patients vulnerable. We are excited to welcome a diverse and passionate group of speakers to explore these issues. We are particularly pleased to be hearing today from U.S. Representative Donald Payne Jr. and U.S. Representative Mariannette Miller-Meeks. And you at home or at your office, joining virtually, are an equally important part of the conversation today. So please ask questions, talk with one another in the chat box, and engage on social media using today's hashtag, Cardiovascular Summit 21. And most of all, stay connected and engaged as we move this conversation into action in the months ahead. Thank you once again and welcome. I look forward to today's event.
Jasmine, Dr. Patel always does such a great job setting the stage for us. Thank you, Dr. Patel. To start our program today, I want to introduce my colleague, Amanda Conchafter, who will lead a discussion on cardiovascular disease and non-medical switching. Amanda?
Thanks, Ryan, and good morning. I'm Amanda Conchafter from the Alliance for Patient Access, and I'm pleased to join you all this morning for a discussion of non-medical switching. We'll define what it is, how it impacts people living with cardiovascular disease, and what policymakers can do to protect patient-centered care. For this discussion, I'll ask Dr. Dharmesh Patel to remain with us, and I'll welcome Brian Henderson, who is board chair for the State Access to Innovative Medicines, or SAME, coalition. But first, we have a new video from the Partnership to Advance Cardiovascular Health on the topic of non-medical switching. So before we begin our discussion, let's take a look.
Hi, I'm calling from your insurance company.
It looks like your heart medicine will no longer be covered by your plan, so we'll have to switch you to a different drug. It's standard procedure, no big deal.
My heart medicine gives me peace of mind so I can sleep at night. No big deal.
My heart medicine keeps me from having a heart attack like my dad, my mom, and my great aunt did. No big deal.
My heart medicine's the only drug that didn't give me awful side effects. No big deal.
My heart medicine prevents me from having a pulmonary embolism. Again, no big deal. My heart medicine keeps me from suffering a stroke during my daughter's piano recital. No big deal.
My heart medicine took 6 months, 3 drugs, and 5 doctor's visits to get right. No big deal.
When your health plan switches your heart medicine, it is a big deal. Learn more and share your story at advancecardiohealth.org/no-big-deal.
And we're back, live in our studio in Washington, D.C., and joined by Brian Henderson and Dr. Dharmesh Patel. Welcome to you both. Dr. Patel, I want to start with you. We know that non-medical switching can occur in a number of ways. So here you have a stable patient who's doing well on a prescribed medication, and then the health plan switches things up. Either they eliminate coverage for the drug altogether, or perhaps they place it on a higher or a non-preferred coverage tier. And that drives up the out-of-pocket cost until the patient has no choice but to switch medications. So to the insurance company, it may be just another tactic to cut costs and boost profits. But from the physician's perspective, Dr. Patel, tell us, why can this be a much bigger deal for heart patients?
Thank you, Amanda. And your point is very well taken. This really is a, quote, big deal. Can you imagine the ramifications of a patient with a doctor and me discussing with them, this is the medicine you need, the patient leaving and they're getting a phone call about actually changing that medicine, This brings a lot of uncertainty. And I have to say, it's not the patient-doctor relationship anymore. It's the patient-doctor and the health insurance. There's three people in the room at all times. And as I've said before, when people have to change their medicines, that can potentially mean the patient's out of the medicines. That can potentially mean that these chronic diseases such as heart disease, heart failure, hypertension, cholesterol, diabetes. These disease states can sometimes get worse over those periods of time. And yes, the truth of the matter is we get phone calls. My nurses are working on that out of the scene trying to take care of these things, and we are working hard to try to get these patients back on these quote life-saving medicines. Some of these medicines, for example, like heart failure, if we don't get the right medicines or give the patient the right medicines, that patient is potentially likely to go back into, for example, the hospital for a heart failure admission. I mean, we know heart failure is the #1 DRG diagnosis in America, where we can prevent people from going back into the hospital. And of course, when people don't take their medicines, we know that it's the #1 cause of disease or death in America. That's cardiovascular disease. So of course, when it comes to the heart, all of these medicines are important. And respectfully, having been in medicine for 20 years now, we have a very good insight into what medicines work, which medicines don't work. At the end of the day, why are we doing switching? We're doing switching to, for the most part, maximize insurance company profits. However, do we consider the things like efficacy? Do we consider adherence? Do we consider side effects? These things aren't really discussed. We treat patients one at a time. We are not dealing with patient populations. So we like to individualize the care to maximize their longevity. And so to me, I think it's a very, very big step to try to challenge this issue about medical switching, because I certainly think we have opportunity. And more importantly, we now have therapies that can make patients live longer and have a better quality of life.
Thank you for that, Dr. Patel. So it sounds like non-medical switching can have pretty serious medical implications. Brian, I want to hear from you. Do you think that policymakers, be they decision makers at the health plans or legislators at the state or federal level, do you think they understand the potential impact of non-medical switching?
So despite what Dr. Patel said, I don't think they do. And I think that speaks more to the necessity of continued advocacy and raising awareness about the impact that it can have on patients than any sort of insurmountable roadblock. I think that the argument, against non-medical switching that, you shouldn't risk adverse consequences when a patient's condition is being successfully managed makes a lot of intuitive sense for everyone, legislators included. And there's a reason that the phrase, if it isn't broke, don't fix it, has become such a, commonly recognized platitude in our society. And across the country and even at the federal level, policymakers and legislators, they've all recognized and acted to correct the harm that overzealous access restrictions and utilization management have caused to patients in some of the other policy rounds that we tackle. And that gives me reason to believe that the current gap in understanding and recognition can be bridged through sustained advocacy and education. I think that what the video we saw earlier conveyed and what Dr. Patel conveyed indicates that there's a lot of technical nuance that goes into the prescribing process in terms of the doctor-patient relationship. And so I think it's up to advocates to elevate that sort of nuance with policymakers, with legislators, with the folks who are making these decisions at the health plan level. Legislators, other policymakers, they have a limited amount of time on their hands. And, you're not the only issue that they have to consider in any one given day, particularly at the state level where sessions are kind of, for the most part, shoved into about a 3 or 4 month period. Time is of the essence, and it's probably the most scarce currency that anyone has. So it does require a sustained amount of effort, and certainly something that I think the video and kind of the purpose of the summit here is to do.
Right, no, that's a great point. So we've talked about the potential medical impact that non-medical switching can have. I want to explore for a minute the emotional effect. So I'm thinking specifically of some research that the Alliance for Patient Access conducted in 2019, looking at patients across disease states, across the country, who had been non-medically switched. And in that research, a couple of themes rang very clear. One was that patients obviously had an emotional attachment to their medication. So the majority said that they'd had to work really hard with their provider to find the right medication. And then 9 out of 10 said that they depended on that medication to go about their daily lives and that it was important to them to keep taking their medication. So, Dr. Patel, did these sentiments sound familiar when you think of your own patients and their experiences?
It's funny you mentioned that, Amanda. I was seeing patients earlier today and yesterday. Yesterday, I had a patient who was on heart failure medicines, which were changed. Today, I had a patient who had high blood pressure and the medicine was changed. My point being, number one, as a provider, I think there's an ethical issue about changing medicines, I feel personally. Number two is there's nothing said about the amount of effort it takes in the back rooms where, we, for example, get a phone call from the pharmacy saying this is not approved. Then my nurses work on it. Then the patient finds out that they have to go through this process of trying medicine X before they can do medicine B. And I want to make it clear, it doesn't mean generic versus brand. It can be for brand versus brand too. We have to appreciate that the technology and the science is changing all the time. For example, medicines for, let's say, the SGLT2 inhibitors, medicines used for diabetes are now being used for heart failure, are being used for heart disease. Not every single SGLT2 inhibitor is a therapy for every single condition. There are certain SGLT2 inhibitors which have been FDA approved for certain cardiac conditions. As a provider, I'm always trying to individualize the therapy depending on what that patient has. Unfortunately, not every patient is the same. In fact, I would argue every single patient is unique, and we have to adjust our medicines accordingly. Remember one point. Yes, we understand medical switching is before reducing or maximizing profits for health insurance companies, but think about the fact that it actually may indirectly increase total healthcare costs in terms of patients not having efficacy, patients having side effects, adherence. Think about the fact that combination pills are more likely to be taken than patients that are separated. So these are just practical things that we are dealing with on a day-to-day basis. The thing that hurts me, I think, the most is the fact that respectfully, I feel as a provider, I've been trained to give patients the best medicines which are scientifically proven and FDA approved. It hurts me to think that once my patient leaves the room, I'm being told, I think by essentially non-medical people, that there are other therapies which are cheaper, which are not necessarily FDA approved for those certain conditions. So yes, it's very disheartening for the patient. I'm very concerned about the fact that this goes on. And of course, when patients don't take their medicines, you ultimately see them back either in the obituary component of a newspaper or you see them in the hospital once again. And then your healthcare costs go exponentially high again.
Thank you for that. So it sounds like, yes, the patients are frustrated, they're upset. It's upsetting the relationship between the provider and the patient. But then also, as you mentioned, there are some downstream implications in terms of cost to the healthcare system as well. So Brian, I want to shift our focus to the policy responses that can limit non-medical switching. So one challenge I think that advocates face is clarifying for policymakers the difference between step therapy and non-medical switching. How is confusion on that topic hindering policy change?
That's a really good question, Amanda. And I think it would be helpful to begin by level setting for the audience. So we're operating off all the same information about the differences between step therapy and non-medical switching, because there certainly is overlap between the two issues, but also some important differences in terms of the mechanisms for how they actually occur. So in general, step therapy requires patients to try and fail one or more drugs before they're receiving coverage for the drug that their prescriber believes to be suitable for them. Non-medical switching occurs with stable patients who have already received coverage for that drug. And a plan or a PBM will exclude coverage for the drug. They'll move it to a more restrictive tier, implement additional utilization management requirements, such as a new step therapy requirement or other barrier, or use some sort of like other prevailing means that forces the patient off the drug after they're receiving a positive therapeutic outcome on it for reasons other than health or safety. And so you can see then where some of the conceptual overlap can occur with policymakers, because implementing new or additional step therapy requirements is one of the ways that non-medical switching can occur. A lot of the messaging around the issue can be similar too. We want patients to get the right medicine at the right time, and focusing on the doctor-patient relationship as the primary means for making these prescribing decisions is a message that's shared between the issue areas. As chair of the State Access to Innovative Medicines Coalition, which serves as the primary vehicle for pursuing these step therapy policies in the states, a lot of the arguments that Dr. Patel just made against the practice of non-medical switching are also arguments that we make in state capitals to support support step therapy policies. So when you have a state that's passed a step therapy law, it's often the case that legislators will say, hey, well, we've already addressed this when a non-medical switching bill has come up. And that can take some of the urgency out of the legislature when trying to rally support to address the problem, some of the wind out of the sails of the legislation, certainly. But I don't want to suggest that these policies compete, that advocates need to choose one or the other. They're both deeply important to patient communities across the country. And what it really means is that we need to look for better ways to clarify the differences between the two policy areas. Highlighting those differences will be, I think, crucial for successful campaigns. And I think in this case, it really means being able to tell the story about how formulary exclusions, how they impact patients, because that's really the main difference here that we see in terms of the mechanisms via which non-medical switching occurs via formulary exclusion as opposed to a step therapy policy. In some ways, the step therapy policies, I mean, they can help because they expose legislators to arguments about the overreach of certain utilization management policies. So it's about finding that happy middle ground, finding a way to capitalize on that while putting a spotlight on those exclusions and kind of how they're impacting patients.
Right, so it sounds like in some cases legislatures have done reform on step therapy and may have it in their mind that they've solved the non-medical switching problem, and sometimes that may be the case. In other cases, perhaps not so. Is that fair to say?
Yeah, absolutely.
So I want to go into a couple of questions that we have from our audience because those watching at home want to be involved in this conversation too, and we appreciate that and welcome that. So first question, Dr. Patel, I'm going to ask of you. So the question is, a lot of people with heart disease are also facing other conditions like diabetes or high blood pressure. How are other diseases and other medications impacted when people with comorbidities face non-medical switching?
Yes, that's a great question. As I mentioned before, the patients that we see today, the average patient in America, we have 30 million people that have diabetes, for example. We have 10 million people that have diabetes and heart disease. These patients are complex. And these patients, unfortunately, are on about 6 to 10 medicines if you go through all the guideline-driven medical therapy. And they are all intertwined. Because, for example, if someone's cholesterol is not controlled, that ultimately will affect heart disease. If someone's diabetes is not controlled, that may affect heart disease and other risk factors. If someone's heart failure is not controlled, then they go into heart failure. The point is there is a spectrum or overlap of this quote cardiometabolic syndrome. It's not just one patient has diabetes and one patient has high blood pressure. It doesn't work like that. These patients have a plethora or an overlap of these disease states. So when you start changing one medicine, if someone has, let's say, heart disease, and you start changing their diabetes or heart failure medicine, well, guess what? They're going to unfortunately go back into heart failure, and that may increase the stress of having a cardiac event. So yes, all of these things are connected. High blood pressure will affect strokes and heart failure and heart disease also. So they are so intertwined, and it's very challenging as a provider when you're faced with a call from a pharmacy that we're changing it to this, when that's not really what's going to help them, because as a provider, that you've given them potentially the best medicine in that disease class for that FDA indication. So then I found, for example, this week, a patient whose blood pressure, they changed it. It was high. It caused him to come back to see me in the office. He was panicking because his blood pressure was in the 160s. He came back again. I mean, to me, that was an unnecessary visit, because if we had just stuck with best clinical decision-making from a provider, this would not have happened. And of course, if his blood pressure remains high for long, he will go on and have heart failure, and then his diabetes will go out of whack too. So it's all intertwined, unfortunately. And so it's extremely important that non-medical switching does not happen in these, quote, complex patients.
Right, thank you for that, Dr. Patel. And then the next question we have from the audience, and Brian, I'll ask this one of you. So the question is, sometimes it seems like the only thing policymakers care about when it comes to healthcare is costs. How can advocates counter insurance companies' claims that non-medical switching is what they have to do to keep costs down?
Yeah, I mean, that's the big elephant in the room in any of these debates about utilization management whenever we're in state legislatures advocating for this type of legislation. the health plans will kind of come in and say, well, if you undermine this utilization management technique in any way, costs will skyrocket, premiums will go up, et cetera, et cetera. I think that part of it is about passing these state policies to gather the empirical proof that no, they actually don't impact cost in the manner that they're suggesting. The sky isn't going to fall, et cetera, which I think we've been very successful in doing in many cases. But for the non-medical switching issue in particular, I think that for an issue such as step therapy, some of the other utilization management reform issues, they're a little bit orthogonal to this price debate, whereas the non-medical switching one, because of its relationship to these formulary exclusions, is a little bit more directly implicated. So I think Dr. Patel raised a really good point earlier, which is that there are these downstream costs of non-medical switches, particularly when patients experience these adverse events, and it sends them into sites of care that are more expensive than providing the proper treatment in the first place. I mean, if a patient's condition is being successfully managed, you're successfully avoiding costs that they would otherwise incur. And I think highlighting that message is going to be extremely important, because there is no getting around the fact that health plans will oppose these bills based on the idea that they'll raise costs because they reduce their flexibility to manage utilization of high cost therapies.
Right, so it sounds like a well-managed patient is probably the best cost saver that anyone can ask for. So we have time for one more question from the audience. And this is a question about pre-existing conditions. So if we guarantee coverage for pre-existing conditions, doesn't it follow that coverage should guarantee access to pre-existing prescriptions for those conditions? Brian, do you want to tackle that one?
Sure. Yeah. I mean, this might be an indirect answer to the question, but I think sort of the totality of the policy environment that we're pursuing kind of in the states at the federal level all sort of builds towards that question. And I think with respect to stable patients, there's some stuff that we already have done to help protect those patients, whereas pursuing some of these non-medical switching policies certainly will help us kind of tackle the problem in totality. I think we talked a little bit about sort of, there being some confusion between step therapy and non-medical switch and the approach between those two things, but they're also related as part of the solution. We've got roughly 30 states that have some form of step therapy reform law in the books. We've got some more bills pending this year. Of those, 20 states have a provision that will help keep stable patients in state regulated plans stable on their medication. One of the mechanisms that we actually discussed here by which non-medical switching occurs is the use of new step edits when a patient is already stable on their medication. Say the formulary changes in the middle of the year and a new step prior to the drug the patient is stable on is added. Sometimes the plan will try and make the patient retroactively go through that new step, or maybe say that the patient has switched insurances and the new health plan wants them to go back through the step therapy process again. Maybe they want them to try and fail the same drugs they already tried. Maybe the plan covers or prefers different frontline therapies. In any case, the law in those states will help prevent patients impacted by these situations from being switched. The laws require that those state regulated plans grant an exception to their step therapy protocol in such a circumstance. And so this goes a long way, I think, in to helping resolve those non-medical switches that occur pursuant to internal formulary insurance enrollment changes. But keep in mind that the drug still has to be covered by the plan's formulary. So you have this whole other area of formulary exclusions that are driving non-medical switching, and those exclusions are accelerating and it certainly need to be addressed. I think the larger point here is that there is some form of recognition by policymakers that this kind of general heuristic that you're citing is an important one for public policy as it relates to the health of patients. It's a question of kind of how can we then tackle the totality of the problem by pursuing these other solutions and fixes to the things that we haven't already done.
Thanks for that, Brian. Well, that's all the time that we have. Thank you both again for being with us this morning. It's an important conversation and one that I hope will continue in the months to come. So thank you both.
Absolutely.
Thank you very much.
Some people living with type 2 diabetes and heart disease are feeling frustrated, exhausted, ready for something different, because they're trying to fight one disease at a time. For diabetes, a patient has doctor's visits, prescription medications, medical devices, and dietary guidelines to keep up with. For heart disease, that same patient has separate doctor's visits, separate medications, and a separate set of dietary guidelines. It's a lot, and it doesn't always lead to optimal health. But with a more patient-centered approach, care could be more efficient and more effective. That might include a cohesive, team-based approach to treating patients with both conditions, access to dual benefit medications, which address both diabetes and heart health, greater awareness of medical guidelines that streamline treatment for high-risk patients, and insurance coverage that keeps novel medications and individualized care within reach. If the pandemic proved anything, it's that patient-centered care is essential. That's why now more than ever, policymakers should ensure that patients have the most current, most effective approaches available for managing both their diabetes and their cardiovascular health. Learn more at the allianceforpatientaccess.org.
Here's Paul. 2 years ago, his disease was making life miserable. Today, he's finally stable on a medicine that manages his symptoms. Then, something changes. Paul's insurance company decides to boost profits by pushing Paul to a less expensive medicine. Maybe they cut Paul's medicine from their list of approved drugs, or maybe they increase his out-of-pocket cost until he just can't afford it. Either way, it's called non-medical switching, because Paul is switched for reasons that have nothing to do with his health. What happens? Paul gets sicker. His symptoms come back. He fights new side effects. He even winds up in the ER. Paul's no longer stable, and his extra doctor's appointments, labs, and hospital visits are actually costing the insurance company more. Patients like Paul need policymakers' help to stay healthy, stay stable, and stay protected from non-medical switching. Learn more at patientaccesscollaborative.org.
Amanda, that was a really great panel. Thank you again. I especially love that first non-medical switching video. The sarcastic humor really sheds light on such an important issue that impacts patients' lives every day. Today, as you all know, we are in Washington, D.C., the place where problems go for answers. So let's talk about another topic that's getting more attention right now: lack of access for seniors living with cardiovascular disease. To kick off this discussion, I'd like to welcome my colleague, Lindsay Vidyanex, CV Working Group Manager for the Alliance for Patient Access.
Thanks, Jasmine. That's right. Often we don't hear much about Part D policy in the CV space, even though it is such a common comorbidity to so many other conditions. So I'm particularly excited to introduce an expert who's going to break it down for us. He'll cover the creation of Part D, what's working and not working, and what CV patients and providers can do to engage on the issues. Please join me in welcoming a policy expert who helped advocate on behalf of Medicare Part D. Andrew Sperling is Director of Legislative and Policy Advocacy at the National Alliance on Mental Illness and has had that role since 1996. He had an influential role in helping to develop the Medicare Modernization Act that established the Part D program. Andrew, welcome. We're so lucky to have your perspective.
Good to see you.
Thanks for being here. So, good to see you. So we're excited to have a pretty substantive conversation about Part D. We're also looking to you to provide sort of a 101 level set discussion because this is an area that the CV community just doesn't talk much about. So let's get things going. I'd like to start off by hearing more about the origin of Part D and sort of how we got here. So can you take just a few minutes to talk about how the Part D program came about and what it was really intended to do for patients?
So it's hard to believe that up until 16 years ago, there was no drug benefit in the Medicare program. The bill was actually passed in 2003, so it went into effect in early 2006. So it's really hard to believe that we didn't have a drug benefit in Medicare. Now, Medicare paid for some drugs, infusion drugs and other types of drugs under Part B, but it took an embarrassingly long time for Congress to get its act together and add a drug benefit to Medicare. That happened largely because in 1965, drug spending was very, very small, but look at the innovations that have happened over the last 50 years in terms of the treatments that are now, effective treatments that are now available in pharmacological form. It clearly a drug benefit was needed. And this the drug benefit in Part D is very, very different from the rest of Medicare. What's interesting is that when you poll Medicare beneficiaries, both seniors and non-elderly people with disabilities that are on the Medicare program, Part D is the most popular part of the Medicare program, in part because we put a number of measures in the Part D in that legislation that ensures access, and really broke through. And this was a challenge at the time, but the idea that up until then, we operated under a principle that every single Medicare beneficiary had the same benefits. We broke that mold with Part D. And that was important because we understand the homogeneity of the Medicare population and the varying needs of people. So that, for example, a retired CEO who lives on a golf course in Arizona has very, very different needs than a widow on survivor benefits, maybe an African-American woman living in Mississippi who's dramatically poorer with less assets. So this program, what's important is the benefits are different for different people because their needs are different.
And, can you talk a bit about the 6 protected classes and how that was built into the program, and then maybe why they were chosen, a bit of that history as well?
So another thing that makes Part D unique is that the delivery mechanism, if you will, is not a government-run program, but rather private health plans that offer drug coverage to Medicare beneficiaries, okay? So we're relying on private sector plans, the same plans that might run your employer coverage, Cigna, Aetna, Blue Cross Blue Shield, United, all these different plans offer coverage that's different in different parts of the country. So what we wanted to ensure was that there's open access, particularly for particular therapeutic classes where the drugs are not interchangeable. I know you've been hearing a lot, participants in this seminar have been hearing a lot about non-medical switching. That's something we're concerned about at NAMI and many other patient groups. But the fact of the matter is, with our medication, many medications, therapeutic classes, the drugs are not clinically interchangeable. And so there's 6 therapeutic classes for which the Centers for Medicare and Medicaid Services has walled them off and put extra requirements on health plans to have broad coverage. And the exact phrasing of this is what's called all or substantially all. The plans have to offer coverage for all or substantially all the drugs in 6 particular therapeutic classes: anti-neoplastics, which are oncology medications; antiretrovirals for HIV/AIDS; immunosuppressants for people that are recipients of an organ transplant that need to suppress the immune system; anticonvulsants for people with seizure disorders; and then the 2 that are important for NAMI, antidepressants and antipsychotics. So this has been in place since 2006 when it was sub-regulatory guidance, and Congress has codified this not once, but twice. So while this policy is broadly supported by patient organizations, unfortunately, administrations of both parties, Democrats and Republicans, have tried to undermine it. And that's largely because the Part D health plans have tried to make a case that this requirement for broad coverage adds to extra costs. In fact, it really doesn't. I'll give you an example. In the therapeutic class of antidepressants, 97% of the Part D claims for antidepressants are for generic drugs, low-cost generic drugs. So the idea that this is driving costs higher is just simply not the case. And it is a critical patient access protection that needs to stay in place.
Well, I was just going to say, this was legislation with the idea of being patient-centered, sort of that in mind. I want to go back to that concept of dual eligibility that you were talking about in terms of, not treating everyone the same as a homogenous pool. That might have been sort of one of the earlier sort of social determinants of health considerations in this type of legislation. But can you explain the dual eligibility concept a little more for the audience who may not be familiar?
So I misspoke a little when I said that no one on Medicare was getting a drug benefit. Prior to 2006, there were a classification of Medicare beneficiaries that were getting drug coverage, not from Medicare, but from their state Medicaid program. So these are Medicare beneficiaries who are below a certain level of poverty and are concurrently eligible for Medicare and Medicaid. And up until 2006, state Medicaid programs offered drug coverage. Now, weren't required to do it, but all 50 states did. But the challenge with that was that some states, for example, would limit you to 2 or 3 prescriptions a month. So we know with someone who's got heart disease, hypertension, and comorbid depression, limiting them to 3 or 5 prescriptions a month was wholly inadequate. And many of these states had very restrictive formularies for their drug coverage. So it was drug coverage, but for the most part, it was inadequate. And we can say safely when people dual eligibles transition from Medicaid coverage for their drugs and switched over to Part D in 2006, their drug coverage in many cases got dramatically better. Why is that? Also, I mentioned the differential. So if you are dually eligible or you qualify for something called a low income subsidy, below about 138% of the federal poverty level, you have very, very durable, deep drug coverage. You are able, if you pick a plan below the average benchmark, you pay $0 monthly premiums, and your cost sharing can be limited to as little as $3 or $5 per prescription. So these are low-income people, and Part D really serves them well by providing a subsidy, so they don't, in many cases, don't have to pay a monthly premium, have very minimal cost sharing. And also, they were never subject to something called the donut hole or the coverage gap. So the Part D program really works well for these low-income seniors and people with disabilities.
And that's, goes to the whole concept of people generally love their Part D benefit. And it, while it wasn't perfect, it was a milestone event. We talked a little bit about what's wrong with it and why CV patients should care. I think that I'd like to hear a little more from you about sort of the multiple disease or comorbid conditions and how that impacts when you're a Part D patient in trying to get access to coverage.
Yeah, so we know that many people out there with the chronic disease drives a lot of cost, and poorly managed chronic disease is very expensive, which is why medication adherence is so critically important, because we know that in many cases people just don't have hypertension. They also have heart disease. They might also have COPD and maybe even comorbid depression. So good drug coverage is very, very important for them. And there are some improvements we can make, because there are some people that don't get the low income subsidy and are middle income. They are subject to very high out-of-pocket costs. So there are two things we're trying to do, and we're working with Congress to do, hopefully this year. One is an out-of-pocket cap, hopefully as high as maybe $2,500 or $3,000. Once they reach that, their out-of-pocket spending is capped. And another one is what's called smoothing. And what smoothing is about is people that have a very high-cost drug, like an oncology drug, that they could a mechanism to smooth that cost sharing, so it's the same constant cost sharing throughout the calendar year. And we're continuing to work on both an out-of-pocket cap and smoothing to help beneficiaries that really have very high out-of-pocket costs and need an improved benefit in Part D.
And I think you just answered my next question, which was sort of, if you were Congressman Sperling, what would be, what would be your, doable, reachable, there's a saying in Washington about don't give up the good for the perfect. So let's shift gears and talk a bit about policy solutions to some of these issues. So what are the most viable reform vehicles as you just described? We know there are several ideas and initiatives out there, but what do you sort of foresee in your crystal ball could happen?
Yeah, well, certainly the out-of-pocket cap and the smoothing are a big, big priority. But there are also, even though I was just saying how well it works for dual eligibles, there are some improvements around the edges we can do for dual eligibles, particularly around the plans they're enrolled in, and even doing something about improving some of the, we can go even further to improve cost sharing for them.
Okay. Well, let's shift gears to the advocacy community role, because you've been in this fight for a long time. I'd love to hear more from you about, what groups like NAMI have been doing, but also how the CV community can engage, right? So if we are a newer community in terms of trying to add support to some of these reform initiatives, what is sort of the best way to engage at this point?
Certainly the education of beneficiaries. The program has worked really, really well, but there's more that can be done to educate Medicare beneficiaries about drug coverage, and then also educating your members of Congress and policymakers about innovation in particular. We at NAMI, I've been at doing this work a long time. We can always do better in terms of research and development. And it's critical to tell that role, the role that the private sector plays in innovation, bringing new products to market, collaborating with academia and government-funded research to advance newer and better treatments. The pace of innovation, I can tell you, in psychiatry has been painfully slow over the years. We're getting new medicines, and there's an uptick there, which is really exciting. But we need to continue that innovation. We need to make sure that policymakers understand that when we get newer, better therapies, that having access to those newer, better, new and improved therapies is absolutely critical. And then finally, I'll mention many of our advocacy.
Yeah.
I'm sorry. Just one last thing.
Go ahead.
Congress will be going through a renewal of something called of user fees, something called PDUFA, the Prescription Drug User Fee Act. Patient advocates need to be very involved with Congress. These are user fees that the pharmaceutical industry pays to the FDA to make sure that the FDA, in a timely way, reviews the clinical trial data that the sponsors submit. And patients need to have a role in that process as well.
I want to go back to, if you don't mind, some of the reform measures we were talking about, because I want to have a little bit of a conversation about rebate reform. One of the challenges of the program is that patients' cost obligations really based off the list price, not the negotiated price. So we have middlemen who negotiate, a price rebate, but then ultimately don't end up passing that along, the cost savings to patients. So can you talk broadly about why that might be a problem for seniors? And we've taught you, I think a common theme in this whole summit has been, those in the chronic disease community who have expensive, comorbid conditions, why that matters to them.
So I want to flesh out a concept here, and sometimes people get confused. So we have cost sharing is what you pay at the pharmacy counter, okay? But what's important to understand is whether that's a set rate, like say $5 for a generic, $30 for a brand name. That's cost sharing. We know what that is, and they'll tier it. They'll say the first tier it might be a $30 copay, second tier $50 copay, fourth tier, the most highest for a very high cost drug, $100 or $150 for cost sharing. That's what cost sharing that people understand. There's also something called co-insurance, and that's not a flat set amount. That's a percentage of the list price, okay? And I'm going to draw a distinction between the list price, okay, that might be available on the internet or wherever these things are tracked, versus the negotiated price, where the PBM, the pharmacy benefit manager, and the insurance company negotiate with the brand manufacturer and get significant rebates and discounts. That's a sort of hidden price that no one knows about. And the co-insurance is based on that list price, which is going to be dramatically higher. So when we talk about 40% cost sharing for a very expensive drug, that's going to be really, really expensive for a beneficiary. So what we want to see is more transparency and have that cost sharing and co-insurance be assessed on the basis of that negotiated discount price. And this is also a means of passing on that discount, that savings, to the patient, to the consumer. We need to see more of that. And we actually had a rule during the Trump administration that would have reformed all this, but the PBM's industry, their trade association, PCMA, Pharmacy Care Management Association, they actually sued to block that. So it's still in limbo of what that's going to happen, but we need more transparency, and we need to see those rebates and those discounts passed on, those savings shared with the beneficiary.
Thanks, Andrew. So historically, as I mentioned, it has been the 6 protected classes advocacy groups like AIDS, oncology, mental illness, doing all of the work. You talked a little bit about how the CV community can engage. Are there coalitions or other sort of larger advocacy efforts that we can join and engage in?
So this is for organizations, not for individuals, but there's a coalition called MapRx. My colleague Bonnie Duffy runs that organization, and they try and be. They are a coalition of patient and disease advocacy groups that focus just on Part D. And I would urge organizations in the CV area to be a part of MapRx. There's also a coalition called the Partnership for Part D Access, and it works on Part D, but only on the 6 protected classes. And there are a number of patient and disease advocacy groups that are involved in that coalition as well, and worked very, very hard over the years, because I think I mentioned earlier, unfortunately, both the Obama administration and actually going back to the Bush administration, they tried to undermine it at one point. The Obama administration tried a rule that would have undermined it, and the Trump administration, not once, but twice, sought to undermine the policy. So we continue to have to educate and advocate on this, because our friends in the health plan industry and the PBMs are somewhat relentless in trying to undermine this policy.
Thank you. And, what about a role in advocating to CMS directly? I know that the Senate has just confirmed recently, Ms. Chakia Brooks-LaSure is the new CMS administrator. Is there a role for patients or maybe through the coalition to advocate on a list of priorities and some of these issues directly with CMS?
Absolutely. And one area that we've been trying to work with CMS on is something called CMMI, the Center for Medicare and Medicaid Innovation, because there's a lot that can be done in terms of innovating Part D, particularly relative to integrating care, right? And what we mean by integrating care is looking at the whole care of the individual, not focusing just on drug costs, but when someone doesn't access the right therapy, the fact that they end up in the hospital and engaging in very, very high cost care. So we need to do a lot around making sure that Part D is integrated to the rest of the of Medicare and the cost of Medicare to ensure that we get better outcomes for the whole health of the individual, and looking at the role that prescription drugs play and avoiding hospitalization and avoiding high cost bad outcomes.
So we've kind of come full circle here, and I'm going to ask you to look into your crystal ball at the end of this, because you've educated us on the history of the program. We've talked a bit about what's working, what's not. But, Congress is going through a major infrastructure package right now in terms of room on the calendar. What do you think this Congress is going to be able to do to help seniors and their beneficiaries in terms of what might actually get done, if you were to think about it?
Yeah, that's a tough one, because we remain very divided. And unfortunately, Part D passed on a bipartisan basis. People forget that. There were many Democratic leaders in the House that opposed it, but it was a very bipartisan vote in the Senate. And that's how far we've come since it passed in 2003, that healthcare has become a very divisive issue relative to the ACA and the efforts when Republicans got in control to repeal and replace the ACA. I'm not terribly optimistic of us coming together. I think the challenge is that for the Democratic leadership, particularly in the House, they have tied any reforms to Part D to proposals that focus just on drug pricing. NAMI didn't take a position on what's called HR 3 when it passed in 2019, but that the issue of drug pricing can be very, very divisive and very partisan. And unfortunately, if reforms to Part D continue to be framed as part of a major drug pricing bill, I think that the chance of getting bipartisan support to advance it's going to be really challenging.
Well, we'll stay tuned on all of that, and I want to thank you for your leadership and NAMI's role in really moving the ball forward. So with that, I want to thank our panelist, Andrew Sperling, for his truly inside view of Part D, the legislative intent, the real-world impact of the program, and how it can truly reach its full potential. And I'd like to turn things over at this point to my colleague, Jasmine Patel. Jasmine?
Lindsay, what a great panel what a great panel. It's always interesting to see how programs like Part D come to life. And although imperfect, they are a huge help to so many Americans. Now I'd like to welcome Olivia Medina, our team member who has been instrumental in helping us plan this program and truly keeps Ryan and me in check.
Thanks, Jasmine. Good afternoon, everyone. My name is Olivia Medina, and I hope you have enjoyed our two panels so far today. Now, normally at this time, we have a speaker and enjoy a quick lunch before we finish up the summit with two more panel discussions. Today's lunchtime speaker, however, is the Congresswoman from Iowa's 2nd Congressional District, Mariannette Miller-Meeks. Unfortunately, the Congresswoman couldn't join us today live, but luckily, Ryan had the opportunity to talk with her earlier this week. After their discussion, we'll go to a short break so you can grab a quick bite to eat or get that coffee, and we'll be back at 12:55.
Representative Miller-Meeks, it's so great to see you. I know you're extremely busy, so thank you so much for taking time to speak with us today.
It's my pleasure. Happy to be with you.
So what we're talking about today is how policy impacts access to care, specifically for heart patients. And oftentimes, though, when I think about policies that impact heart disease patients, I really think we're talking about the healthcare system as a whole, frankly, because heart disease and its comorbidities impact so many Americans and so many Iowans where you're from. But I'm excited about our conversation because I know that you're uniquely qualified to talk about these kinds of issues regardless of disease state, because you have a rare distinction that many in Congress don't have, and that's that you're a medical doctor and had a career in medicine before you shifted to public service. So to get us started, I just wanted to ask you, can you talk a little bit about your life before and outside of public service and what motivated you to become a doctor?
Well, what motivated me to become a doctor, and it's a very convoluted process, as was my process to getting into Congress. My father was a master sergeant in the Air Force. My mom had gotten a GED. Both my parents wanted college education for their 8 children, but weren't really sure how to navigate that. When my dad was stationed at Wright-Patterson Air Force Base in Dayton, Ohio, I was severely burned in a kitchen fire. And during that very long hospitalization, I had this wonderful physical therapist and decided I wanted to be in the medical field and help people like the physical therapist helped me. And I had a wonderful doctor. I just never saw him because we were in isolation. So it was infrequent interactions with my physician. But physical therapy for burns is extremely painful. So I decided I would become a doctor rather than a physical therapist. And I came home from the hospital, told my parents this. And my parents were, I won't say they were dismissive, but they tried to dissuade me because they just didn't think that someone from very poor circumstances, humble circumstances, would be able to go to medical school. At this point in time, my dad gets reassigned to Lackland Air Force Base in San Antonio, Texas. So I left home at 16 to figure out how to work and put myself through school. I started at San Antonio Junior College. I found out that the Army had a program for nursing, and I said, well, if I'm a nurse, I could work at night and go to med school during the day. So I actually enlisted in the Army at age 18. I kept working and going to school, got a degree in nursing, a master's in education, and then ultimately was able to get into medical school and go to medical school. So I got into medicine because I wanted to help people in the way that I was helped when I had my burns. And I was good at science and math, so it seemed like it was a natural fit. Loved my time as a nurse. And as a matter of fact, even when I was a physician, I stayed in the reserves in the military. So I ended up spending 24 years in the military, but I worked most of that time as a nurse until I changed to the medical corps because I had already been promoted to major as a nurse. So I was both in, military medicine, military nursing, academic medicine as an assistant professor at the University of Michigan and University of Iowa when I finished my residency. Then I was in private practice. I was director of the Iowa Department of Public Health, and then I was an employee of a hospital here in the district until I went to Congress and then stopped my practice in January of 2020.
So we're talking about solutions for patients at the Policy Summit, and one thing I know that you hear about in your district is prescription drug pricing. And one thing that's interesting to me around Washington is that there seems to be some bipartisan consensus on pieces and parts of legislation that could actually reduce costs for people. And one of those things is rebate reform, which I know that you were active on in the Iowa legislature. So, for those unfamiliar, a rebate is a negotiated sum of money that a drug manufacturer will make with a pharmacy benefit manager. And a lot of times that rebate determines where a drug might sit on a formulary, which determines access and affordability for the patient. And what I'm curious of, Representative, is what's your take on rebates, and how do you believe that reform can make people's prescriptions more affordable?
So first of all, let's lay the groundwork for people. So 70% of prescription drugs in the United States are dispensed from a pharmacy benefit manager or a PBM. The PBMs require that in order for a pharmaceutical company to have a drug on the formulary for many drugs, and these can be common drugs, for instance, Humalog or insulin. So these don't have to be new drugs, new therapeutics, new biogenetic drugs. These can be drugs that we've had around for a very long time. But in order to get on the formulary or on a certain tier on the formulary, the drug company will have to offer a rebate to the pharmacy benefit manager. And then the pharmacy benefit manager, so they're making money, and we don't have any transparency of how much money this middleman, if you will, makes on prescription drugs. So that any cost saving doesn't get passed on to the patient. Some of the cost saving gets passed on to the insurance company. The PBMs very recently in the past 5 years have been purchased by insurance company, and now PBMs are purchasing health or medical insurance companies. So you can see that there's a tremendous conflict of interest here. So PBMs, in my mind, are responsible for why insulin 10 years ago, 11 years ago, was $136 a month, and now it's over $600 a month, and people can't afford their insulin. So at the state level, I put forth, I had to do a lot of research. I was first approached to do this, but I really had to do the background and the work in this. But we put forth a bill that would mandate transparency of the PBMs. And part of this is guided by ERISA, so you are limited by what you can do. But our bill specifically asks for the aggregate amount of the rebates, the aggregate amount of the administrative fee that was passed on to the insurance company, and the aggregate amount of the administrative fees that were not passed on to the insurance company. Basically, we wanted to get an idea of how much money we were talking about. And then the second part of this bill was that 51% of the rebated amount would go to the patient, because the patient's the one paying the drug. The patient is the one that has to pay the copay for any of these medications. They should be receiving the rebate, not the PBM, and then not the PBM passing it on to the insurance company. And the insurance company will say, well, if you try to eliminate the rebates, then our premiums are going to go up, because they use the rebates in turn to lower premiums to their contract holders, to their patients. So it's a very convoluted process. It is not transparent. We were not able to get the rebate part through, but at the same point in time in 2019, CMS was looking at banning rebates in Medicare, and I had hoped that they were going to do that, but they did not do that. But we did get the transparency part of our bill through, and I'm looking at doing the same thing on the federal level. So I've been working with Diana Harshberger, who is a pharmacist out of Tennessee. So looking at that, and the situation is even more than just the amount that it costs patients. So certainly it costs patients more. It's costing insurance companies more. But most importantly, it costs patients more, the copays are more, but also all of your independent individual pharmacies. So I'm in a town of 27,000 people. Our independent pharmacies are really struggling because their processing fees, sometimes they will get paid less for the cost of their medication by the PBM and their dispensing fee, and then the PBMs will claw back what they've already been paid. So it's a tremendous issue in the supply chain. It's an issue for your local independent pharmacies, and it's a tremendous issue for patients and the healthcare system as a whole. So we're going to continue to work on legislation at the federal level on PBMs, and we will work on trying to eliminate, ban, or reduce the rebates.
Really complicated issue, but glad we have people like you out there working on it, so thank you. Let's talk a minute about HR 2163, the Safe Step Act, which I know you're a co-sponsor of that bill, and there's a large bipartisan group of legislators pushing that legislation. So the bill seeks to curb step therapy, which is where insurance companies force patients to fail or step through specific therapies before they're approved for the medicine that the doctor initially prescribed. So my question to you is pretty simple. Why is the Safe Step Act necessary, and what will it do to improve patient care, in your opinion?
Well, unfortunately, it's necessary for one of those things I talked about when I first went into politics, and that is the interference with the doctor-patient relationship. And so what step therapy does is that the insurance company, instead of trusting that the physician has already gone through this process with the patient. So when I interact with a patient, I'm an ophthalmologist, and so often it would be eye pain. It's nebulous. It's not easy to describe. So you're looking for sources of eye pain, and if you don't find sources on the surface of the eye, you look for other things. But often people will want to be imaged, and a CAT scan or an MRI are then more costly tests. So for me, most of the time, I have a conversation, discussion with my patient on what I think the benefits are, what the risks are of any imaging studies, what's the likelihood that we're going to have, some result or outcome or information that's different than what we already have, and then what our course of therapy should be. And almost always when I have that discussion with my patients, the result will be that we'll have a conservative management approach, and we'll monitor them, follow them, and then as their symptoms change or if things change, then proceed with other further testing. But in the fail first policy, or in non-medical switching is another thing that insurance companies do. Basically, instead of trusting that the physician and the patient have had this interchange, that they've had this dialogue, that the physician has looked at all of the ramifications of certain medications and decided that what they're prescribing is going to be the best treatment option for this individual based on their medical history, based on their physical findings, based on previous similar medications that may have been tried in the past, or their medical condition and where they are in their medical condition or disease state, that the insurance company, in order to save costs, is going to mandate that you first try a less expensive medication or a generic medication, rather than trusting you as the provider to have had that conversation and interaction with your patient, both in their history taking and in your physical exam findings and in your knowledge of their disease course. So basically, to me, what it is doing is that it's usurping the patient-physician interaction relationship, and it's saying, we're going to force you to do this first. Well, what they don't look at and what they don't tabulate is how much that costs. So there's a tremendous cost in changing a patient's medication, if it's COPD medication, or if it's insulin medication, or if it's medication for epilepsy. You can, or an oncology treatment, hematology oncology, or in rheumatology, certain of the new biogenetic engineered medications, which are much more costly, but much more effective. So if they switch a patient, take a patient off a certain medication, put them on a less expensive medication, which may have even been tried 2 years ago or 5 years ago or 10 years ago, and then the patient has been stable on a more expensive medication, there's a cost to that, in that the patient's disease state may worsen, they may be hospitalized, then there's the cost of emergency room visits, the cost of hospitalizations as we go through this process. Some patients have even died while going through this process. In ophthalmology, for us, it's treatment of macular degeneration and what kind of medications we can use to treat macular degeneration, wet macular degeneration. And we'll try a medication successful, but then they'll want us to go back to another medication. So the Safe Step Act was necessary because insurance companies were using their leverage as having the contract with the patient, and Medicare does the same thing, so that they're not adverse or immune to this. It's not just private insurance, but it's to force a less expensive medication, but there are tremendous costs to that, both from the standpoint of how much time it takes for the doctor, but more importantly, the patient's disease status may worsen, and it could even lead to further hospital bills, further care, and even death of a patient as they go through this process to get to a more expensive medication that the insurance company is hoping to avoid.
Well, Representative Miller-Meeks, we thank you so much for being here today. At the Partnership to Advance Cardiovascular Health, one of the things we're trying to do on a daily basis is to get cardiologists, nurse practitioners, patients to speak up and advocate for the issues that you're speaking well to today. So we really appreciate you taking your time. We know you're very busy. Thank you for fighting for patients on the Hill, and we hope to speak with you soon. Thanks so much.
Well, thank you for having me, and you all should feel free to reach out to me. It's wonderful to have a physician in Congress. We need more. So I would encourage your providers. We're in a wonderful, gratifying field to be in medicine, and I miss that a great deal. But knowing that I'm doing things to help, the people you represent, to be able to be there and advocate for them and be their voice and the voice of patients is also very important. So they should feel free to reach out to me. It's miller.meeks@mail.house.gov is my official email address, and would love to hear from them.
Thank you so much. Take care.
Thank
Bye-bye.
you. You all take care. Be safe and be well.
And welcome back to our studio here in Washington, D.C. First, I'd like to say again, thank you to Representative Miller-Meeks for joining us for that discussion the other day. It's really gratifying to hear members of Congress who really understand what patients and clinicians are going through on a day-to-day basis. For our next panel, we will explore a topic that few think about, but all are affected by: clinical practice guidelines. What are they, and why are they important? Medical innovation in the cardiovascular space is moving at a speed which we haven't seen in a long time. But getting that innovation into clinical practice is a long and complicated process. It's often cited that a medicine's journey from lab to FDA approval to clinical guidelines to medical practice can take nearly 2 decades. The cardiovascular community is constantly struggling with the question of how we can speed this timeline up. Our panelists today are Dr. Eileen Handberg, a cardiovascular nurse practitioner at the University of Florida, and Dr. Alexander Blood, a cardiologist at the Brigham and Women's Hospital in Boston. Thanks so much to both of you for being here.
Thanks so much for having us.
We hear clinicians and policy folks lament the problem of clinical practice guideline uptake frequently. Dr. Handberg, can you color in between the lines for us here? How bad is this problem truly?
It's pretty significant. As you mentioned, there's a long lag between drug development and getting it to the bedside. There's about a 10-year gap to get it to the market, and then an even longer gap to get it into patients. It's estimated about 30 to 40% of patients receive treatments that are not based on scientific evidence, and that 20 to 25% receive treatments that are either not needed or potentially harmful. We owe it to our patients to have evidence-based practice. There is definitely some gaps between new data and guideline development. Most of the professional societies will acknowledge that that process, in order to be accurate, is not as nimble as it needs to be. But there are some other gaps. We need to have providers who are willing. First of all, they have to be aware of the guidelines. They have to be familiar with the guidelines. And then they have to be able to implement them into the practice. And there are reasons why that's not moving as quickly as possible. You see this, a simple example in cardiovascular medicine: 1 in 4 patients with high blood pressure are not at goal. These drugs have been around for 50 years. These are not expensive drugs, and there's not a lack of them. And yet we do not have the guidelines being implemented in one of the biggest risk factors for cardiovascular disease. So there's a lot of opportunity for us to figure out how to get providers to do evidence-based medicine following clinical guidelines.
Thank you, Dr. Handberg. So clearly this problem is pervasive. So Dr. Blood, the question for you is, why is it so difficult to get that broad uptake of therapeutic innovation?
Yeah, it's a great question, and a challenge that we struggle with in cardiovascular medicine much more than I wish we did. Clinicians spend many years in education and training and subsequent practice, ingraining these practice patterns that are hard to disrupt. As the pace and the quality of clinical evidence has accelerated, it's really been difficult to keep up with those remarkable advances. And as the data has accumulated, clinical practice guidelines have been a way that really make a Reader's Digest version of how do we stay on top of the best way to treat our patients. Unfortunately, it's really difficult to change practice patterns, change behavior, and stay on top of all this data as an individual clinician. And those barriers remain high. There's therapeutic inertia both on the side of the provider as well as the patient. And I think breaking down those barriers are key to delivering the best care that we can for our patients. So I think you've identified a key issue for the field.
So at our summit, our first summit 3 years ago, we heard from some clinician researchers at the Johns Hopkins Hospital who were using Apple's Watch and iPhone technology to help heart attack patients recover from heart attacks better and faster. Scheduling, reminders, heart rates, and blood pressure were all tracked through the devices that were given to patients. And that was, one example of many of how technology is really changing how we do medicine. And Dr. Blood, I know that you've been part of a program at the Brigham and Women's Hospital that's seen a lot of promise in getting patients to clinical practice guideline goals. So can you sketch out exactly how this program works for cardiovascular patients?
Absolutely, and I appreciate the opportunity to talk about it. So in 2016, our team at Brigham and Women's Hospital and across the Mass General Brigham Network first developed a remote disease management program. Uses electronic health record to screen and identify eligible patients to help optimize their health for hypertension and cholesterol. We're able to remotely engage patients in ways that are easier for them than taking off time in a workday, paying for parking at a hospital and making it into a clinic, spending multiple hours to spend just a few minutes, oftentimes with a provider. We use text, email, patient gateway, which is any sort of secure communication from providers to the patients, to really engage them as easily as it is, however it is easiest for them to really work with us, whether that's, again, text, email, even on the phone. So we're really working to reduce some of those barriers that make it difficult for patients to engage with their healthcare. And by doing that, we've actually seen some remarkable results. We've built a team of pharmacists, patient navigators who help to be our first point of contact and health coaches for the patients, all enabling these algorithms that have been built by clinical experts and based on the Society Clinical Practice Guidelines, so that we can really not just talk the talk, but walk the walk when it comes to getting people to their targets and reducing the burden of cardiovascular disease. So it's been a journey. We're continuing to enroll patients, and it's been a really, really great program for our population here at Mass General Brigham.
When I heard about your program for the first time, I thought we have to get, I'd love to highlight this at the summit. So tell us a little bit, can you put some finer points on some examples of the results you've seen so far?
Absolutely, yeah. So we published our first 5,000 patients cohorts experience at the American Heart Association conference in November of last year. So again, two programs that we published on, cholesterol and hypertension. In our cholesterol programs, the people who finished the program were able to cut their cholesterol levels by more than 40%. And patients with hypertension, if they completed our program, 90% of patients, over 90% reached their hypertension targets, an average drop of 39 millimeters of mercury systolic over 18 millimeters of mercury diastolic when people complete the program. Really just remarkable results. And it's not magic. It's really making it easier for patients to engage, getting them on appropriate therapy, following up that therapy with appropriate lab symptom monitoring and follow-up blood pressures, all done remotely. We've actually now enrolled over 10,000 patients in our program and hope to be presenting the results of that cohort later this year.
So Dr. Hamburg, I'd like to pull you back into the conversation, and I'm curious about your perspective on this, because I know that you're aware of programs like this around the country, and a number of your colleagues at the Preventive Cardiovascular Nurses Association have worked on programs like this across the country. So I'm wondering, thinking back over your career, what are some of the challenges associated with expanding programs like Dr. Blood's?
First of all, congratulations on a phenomenal effort. And, it's evidence that guidelines do work if you follow them. And I think the question that most people will ask is, who pays for it? And, I think that that's a lot of the pressure in the healthcare systems that we have. And so one of the benefits of the pandemic now is that CMS has loosened up its reimbursement, and now telemedicine becomes much more feasible. So previously, if you were going to have had your staff do all this phone calling, they would have been spending the time that you have spent in your group to get these tremendous results, but you wouldn't have been able to get reimbursed for it. So I think, that it opens up a lot of opportunity and makes this kind of program expandable into a variety of settings. Mobile apps obviously make a difference. Telemedicine, patients not having to come in to the visit, but being able to do this more conveniently, I think will help. And it should also, if done right, unburden the internists, family medicine, cardiologists who are seeing the brunt of this wealth of cardiovascular disease, high-risk chronic disease population, and let this stuff get taken care of while they can deal more with some of the more acute episodic things that these patients also come from. They're just, so overwhelmed. So I think this is fabulous and creates a lot of opportunity for us to look at this and model. Kaiser's been very successful. They've been able to get their blood pressure control rates into the 80%. We did this in a large clinical trial with 20,000 participants, and we were able to get blood pressure control at 80%. So it is very doable. Guidelines are achievable, and I think sometimes providers don't think they are.
And Dr. Blood, I'm sure your team's talked about, expansion of your program. This is a chance for you to respond to Dr. Hamburg, but, one question I'd like to follow on is, what are some of the challenges that your group foresees in trying to expand your program?
I think my colleague highlighted the most, the obvious one. These programs truly benefit the patient and the provider potentially by unburdening them from some of the administrative and really clinical work that goes into medication prescription, lab follow-up, blood pressure follow-up. But it has been challenging to figure out, where do the dollars and cents come from? We've been fortunate to be funded internally for our hypertension and our lipid management programs. We have done some partnering with industry and working with disease conditions like diabetes, obesity, and heart failure, where there are opportunities to help people get to guideline-directed medical therapy, but there's also an incentive from pharmaceutical companies and others to really try to get people onto therapy faster and more appropriately. And I think as we grow and expand, there's a number of, whether it's licensing across state lines or if it's working with patients in different care contexts, the type of legal framework that we use to allow pharmacists to prescribe through an algorithm designed by physicians and overseen by physicians is controlled at the state level at the current moment. So there's a lot of barriers, hurdles to jump over, but we do hope that these remarkable results that we've seen over time translate to improved patient outcomes, improve adherence to clinical practice guidelines, and we just get to a place where enough providers, payers, insurers, employers recognize that this is the best thing for their patient, their employee, their health insurance enrollee, and whether through our program or in another mechanism, identify that this model of 15-minute visit with your provider every 6 months or so is not the most efficient or effective way to reach targets and reduce the burden of cardiovascular disease.
So, Dr. Blood, as you've written these papers and published and worked through this program, I'm curious if there's one lesson that you would impart upon our audience from your experience. What's the one thing that has really made the most impact from your program, in your opinion?
It's a great question, and I think it's hard to synthesize. As we discussed earlier, there's so much data out there. There's so many new therapies, new programs, new platforms, new technology. But the one piece of advice that I would have for your audience is that regardless of what's out there, you will always be your best advocate. So taking the time to engage with your provider, preparing for your appointments. I always encourage my patients to get smart on their health, and the more that we provide them with the opportunity to do that we educate, that we communicate, all of which are so important in really helping to decrease the burden of this disease at a population level, at a public health level. But it all starts with you. So everything you can do to advocate for yourself, don't kick the can down the road. There's very much a bias in one's own health and life, the optimism bias that good things are going to happen to me and bad things won't happen to me. And I certainly hope and pray that that's the case for all of you, but I really, I want you to stack the decks in your favor by taking care of yourself, stay active, eat healthy, get on appropriate medical therapy, and work with your healthcare providers to optimize so that you can live the happiest, healthiest, longest life you can.
So I have a question here that from the audience that I want to rephrase a little bit, but I think it hits on utilization management. Dr. Hamburg, I'll throw this to you, and then Dr. Blood, I'll let you answer too. Dr. Hamburg, with the programs like these, where you're out there actively identifying patients who are not on therapy or not on appropriate therapy, you're working to get them on therapy. I guess reason would say, you're identifying more folks that need to be on therapy than the burden on the clinician team to get them on that therapy, and jumping through those utilization management hurdles that we've seen, just increases. So I guess the question is, do you think that, what is utilization management like right now in the cardiovascular space as we have this kind of crush of patients and all these new folks that we're identifying through programs like Dr. Blood's?
Well, it's an interesting question, but I think what Dr. Blood's program shows that if you use a team-based approach, you use people to the fullest scope of their licensure, and you systematize this isn't rocket science. And I know that sometimes clinicians push back from sort of checklists and recipe kind of driven things. And some people view guidelines that way. But what he's been able to demonstrate is if you take a little more systematized approach, you can actually reduce the burden. And, we tend to treat patients in some ways very individually, which is extremely important. But for some of these things, it's just a matter of getting in there, educating them, prescribing the right meds, following up more frequently than we do, involving the patient in the care. And then the end of the day will be, because these are the risk factors that promote heart attack, stroke, and people dying, hopefully we're going to reduce some of the other healthcare burdens that are a result of these things going without being controlled very well. And so I think you have to look about this as an investment to get this going. And it may seem overwhelming at first, but again, this isn't a job of one person, it's a team-based approach. And so I think you have to go into this in a system-wide, figure out who all the right people are. A good medical assistant can make calls to patients and find out, record their blood pressures and report that to a provider who just has to look at the algorithm, and then, maybe the nurse can get the prescription ordered and uploaded in Epic. So it should disperse some of the workload, make this care more efficient, then get better blood pressure, better cholesterol, and then reduce long-term risk. And this is all what we've been accountable care organizations have been asked to do. We've just sort of resisted doing this in a more systematic way. And I think Dr. Blood's program shows that you can do this, do it well. The link here is going to be that not everybody's going to have an institution that's going to subsidize this. So you're going to have to figure out how to get reimbursed for this in a way that, doesn't eat at the patient's insurance benefit to the point that they can't do anything else, but also gives benefit back to the insurance provider in terms of better outcomes in this population.
So, Dr. Blood, I'll let you speak to that for a minute. How's utilization management been? And let me put a little twist on that. Let's thinking about the medications that are more expensive in the cardiovascular space, the PCSK9 inhibitors, the SGLT2 inhibitors, the more advanced medicines. How's utilization management been with this program, with those kinds of medications?
A great question, and my colleague hit on some really important points, and I appreciate that that framing. So some facts out of the program. So a lot of what my colleague mentioned is the writing down of blood pressure, calling into the medical assistant. Fortunately, we work with very closely with an IT team and have developed customer relationship management software Actually, all of our blood pressures are remotely recorded, uploaded, and directly sorted into Epic, directly viewable by the provider and by the team. So we, again, not something that we're able to scale as this is internal, but we're able to send either a Wi-Fi or, depending upon the patient's technical capabilities, a cellular enabled cuff that there's no configuration. They put it on and press the button. They get reminders to take their blood pressure. All of this gets taken care of in the background. We're really trying to automate as much of this as we can. Now, that being said, there are absolutely patients who don't fit within our perfect algorithm. You know, this algorithm works for most people most of the time. And one thing that, getting back to the utilization, you know, so we're able to really use people at the top of their license, automate what we can, and use our time and energy efficiently as our program. In terms of the more expensive therapies, you know, one benefit that we have in really systematizing exactly how we're starting, up titrating, and switching therapy is that it makes it very straightforward if and when we get a request for a pre-authorization or a face-to-face with another provider. There's really, this is all documented, streamlined, it's all logical, it's all preset. And in some instances, we've actually worked with insurance companies such that if we put people through our program for our cholesterol program and they go through our program and they aren't able to tolerate our algorithm of getting them on appropriate therapy to lower their cholesterol with either statin or ezetimibe, we can bypass the entire pre-authorization process for PCSK9. And that's because we've built trust with these payers to say, look, we're doing this in a systemic, organized, algorithmic way. We're doing the best we can on getting them on appropriate therapy to help reduce their burden of cardiovascular disease. If we can achieve that with the therapy that is first line, we need to move on, and we need to not kick the can down the road, really work with these patients to help them optimize their health. And we've been fortunate in a few instances to be able to partner with payers to help achieve that in a more streamlined fashion. I think, you know, it makes a lot of sense that if we're really partnering with our partners in the payer space, you know, we can make this process really eliminate that headache that is the pre-authorization, the face-to-face, the peer-to-peer that sometimes we have to take a lot of time and effort to complete when we know what's right for our patients. So by making it systematized, it doesn't have to be a one-off, a different conversation every time. It makes it a lot easier to just really have a straight up conversation and say, this is what we feel like is best. Let's work with each other to make this care the best it can be for the patient.
It's really encouraging to hear. Dr. Hamburg, final question for you, just to wrap things up. You know, the pandemic has forced us to think differently about how we administer care, and you referenced this a minute ago, and it has really revealed how fragile patients can be when something like the coronavirus is introduced. So taking in everything we've talked about on this panel, how do we need to think differently about guidelines in order to make progress on this issue?
Doing sort of what Dr. Blood has done in his program is thinking, how do you get to the patients in their own space? The pandemic forced us to do that because patients were not allowed to come into our clinics, and CMS had to modify reimbursement so that we could carry out clinical care. And so that has opened a whole new way of interacting with patients in a meaningful way. And so, and unfortunately, or fortunately, you know, we're now reverting back to a direct clinic model because patients do like the in-person interaction, and I do too as a provider. But it still allows us now to think about doing more visits in the interim to try and get patients where they need to go. And, you know, clinic volumes are such that everybody's at capacity, but if you have 2 or 3 visits between those 2 6-month visits, and you can keep working on blood pressure control, then at the next visit, you're not going on to the second line of therapy. You're confirming that the second and third and fourth tier of therapy worked or didn't work, and where do you need to go, and, you know, do you meet the threshold for one of these newer drugs, and do you need to get that approved? Or, you know, did the guideline get you where you needed to go? And, if done appropriately, can be done well with generics and at a fairly reasonable cost to patients. Walmart probably did the best thing for patient care when they developed their $4 formulary many years ago. That opened the door for patients to get access to a wide variety of medications that could get at hypertension and cholesterol in a meaningful way. And again, those are our biggest risk factors for much worse outcomes, and they're relatively affordable even if you don't have insurance. And now if we have these programs that use guideline directed therapy to get you where you need to go, then it's a win all the way around. The one piece we do have to focus on is educating patients about what the guideline goals are. Societies do that fairly well, but that's an area where it will improve the relationship with provider and patient if the patient is more informed. There's so much information on the internet, and a lot of it isn't scientifically valid. But for the things that we have data, we need to get that information into the patient's hands so I know what my blood pressure should be. And when I go to the clinician and they tell me they don't address my blood pressure that's 150/80, I say, I'm not at guideline. Do we need to adjust my medicine? And strengthening that partnership with knowledge, I think, is extremely important. And I think professional societies, while they reach their data out to clinicians and their members, we need to get them to also have an arm of their dissemination plan to be directly to patients so that we're all on the same page about what's required, because there are competing guidelines and sometimes it's very confusing for patients.
Well, that's a charge that we can take here from the summit. So Dr. Blood, Dr. Hamburg, thank you both so much for being here. It's been a fascinating discussion.
It's been a pleasure. Thanks so much.
Next, we're going to talk about another global issue faced by the cardiovascular community, and that's awareness and treatment for peripheral artery disease. And for that, I'll take it to my colleague, Jasmine. Jasmine, take it away.
Thanks, Ryan. Peripheral artery disease, the prevalent heart disease you've never heard of. Often, people associate heart disease with chest pain, shooting arm pain, and/or fatigue. But is your doctor asking you to take off your socks so he or she can check your feet for a heartbeat? PAD affects nearly 10 million adults in the United States. And despite its high prevalence, this form of heart disease remains critically underdiagnosed and undertreated. There are also significant disparities among racial groups for diagnosis, treatment, and outcomes. In fact, studies show that Black men and women have a 30% higher lifetime risk for developing PAD than white males and females. Black Americans also have a much higher rate of amputations, and many can argue that we are in an amputation epidemic in Black communities throughout certain parts of our country. Recently, I spoke to two people living with peripheral artery disease. Their delayed diagnosis and treatment has dramatically impacted their lives. Let's take a look.
Joining me are Elvis Johnson and Elizabeth Beard. Both Elizabeth and Elvis live with peripheral artery disease, or PAD for short. Elvis is 60 years old from New Orleans, Louisiana, retired, and now enjoys spending his time with his grandson. He suffered a heart attack at age 46 while on his way to the doctor's office. Elizabeth is 61 years old from Little Elm, Texas, works full-time, and is an active patient advocate with the American Heart Association. So Elvis, I'd like to start with you. First of all, I love your name. Tell us the day you experienced your heart attack. Tell us about it. You were on your way to the doctor's office. So what was the purpose for your visit?
Well, I was at work and I was getting increasingly tired and chest was real heavy. So I decided, you know what, I need to go to the doctor now. And I'd been putting it off. So I decided to go. And when I got to the hospital and initially gave them the information, I had a heart attack right there on the hospital floor, which was fortunate for me. And that's how I ended up at the hospital.
How long were you experiencing this feeling of exhaustion for, leading up to your heart attack?
It may have been about 2 or 3 weeks, a month maybe, because I was tired. And I'm a person that's always on the go, always moving. And for me to be tired was unusual, and I was sweating profusely and everything, and I just knew something had to be wrong. So finally decided to go. I think if I'd have waited another day, I wouldn't be sitting here now.
That day you had your heart attack. Was that also the same time period where you were diagnosed with peripheral artery disease?
No, that part of the equation didn't come in until a few years after. I was experiencing the pain and the problems with sleeping and walking and all for a while, and I'd been going to different cardiologists, but they were more, I guess, more concerned with the heart as opposed to the legs, and they never really diagnosed it, or they pretty much dismissed it as something else rather than PAD.
And so tell me a little bit about this leg pain you were experiencing. How severe was it?
Well, it was times where I could hardly walk a block or two without the legs hurting, or if I couldn't stand on the legs for a long period of time, I'd have to sit down. Then at night, it would be increasingly worse because I couldn't lay down. Legs would be hurting so bad I couldn't lay down at all. Couldn't sleep.
But you knew something was clearly wrong with you then.
Right. Well, yeah.
That must have been very frustrating.
Yeah, it really was. And like I said, I couldn't get them to address it. They wouldn't look at that part of it until I spoke with Dr. Ferdinand, and he immediately started looking at it and diagnosing the problem.
Tell me about the difference between your relationship with Dr. Ferdinand and what you experienced in the past as you were trying to find a reason for your leg pain and what you were experiencing.
Well, Dr. Ferdinand, first of all, he listened. He listened to me, and he expressed a concern and wanted to find a solution to the problem. He didn't just lump me in a category with, oh, there's just someone with heart trouble and not taking the medicines, things like that, which weren't the case. But then it became more of a personal relationship, because he generally cared about what was going on and how I was being affected by it. He had the doctors do a angioplasty on my legs.
Okay.
And he had them do that. Then he started recommending certain medicines and rehab and exercises for my legs, which helped out tremendously. To give me a better standard of living than what I was dealing with.
Right. Wonderful. Well, thank you to Dr. Ferdinand for listening to you.
Yes.
Let me jump to Elizabeth now. Elizabeth, as I mentioned earlier, you did have a stroke at the age of 42. And when you and I spoke a couple weeks ago, just so I could learn more about your story, you mentioned that every member of your family has had heart disease. So my question to that is, was your stroke unexpected, or were you actively taking care of your health to prevent heart disease?
Well, I would say that my stroke shouldn't have been unexpected, due to my family history. Just about every member of my immediate family has had heart bypass. Back then, I absolutely wasn't taking care of myself. I was, a newly divorced single mom, and just busy taking care of, like most women, taking care of everybody else but myself. I smoked about a pack and a half a day. I drank caffeine all day long. didn't exercise. The day I had my stroke, it was quite a surprise to me. I didn't even know what was happening to me.
Right. That must have been scary. And so, how soon after your stroke did you become diagnosed with PAD?
I did not get diagnosed with PAD till about 10 years later. In 2012, February of 2012, I had finally decided to quit smoking. At that time, I had smoked for 35 years. And so I was going to walk as part of that plan. And I noticed that when I would walk, my calves would cramp up and my feet would go numb. But my feet had been going numb for the last 10 years. And the doctors would tell me that, I had plantar fasciitis, needed new shoes, or it might be, related to my stroke. But I had started some new medication for depression, and my legs started feeling like they were burning and they were kind of like on fire. And the pain was so intense. My husband took me to the emergency room, and they did some x-ray or like ultrasounds to see if I might have blood clots or something like that. And they didn't find anything. So they gave me a prescription for Ativan and told me that I needed to see a PCP about anxiety. And, I was really kind of mad about that because I knew in my heart that wasn't the problem. But I did go to a new PCP, my husband's doctor, and told him, what was going on when I walked. And so he said, well, let's take your shoes off. And he started feeling my feet and checking my pulses. And I could tell by the look on his face that something was wrong. And he said that he could barely feel a pulse in my feet, but he needed to run a test called an ABI test. So a couple of days later, I had that test done, and the test had come back severely abnormal. And he referred me to a cardiologist and a vascular surgeon. Right. And they came back and told me that my aorta and my femoral arteries were almost completely blocked. And so on May the 1st of 2013, I had a bifemoral aorta bypass.
Wow. Goes to show you that intuition is stronger than anything. But I'm glad you kept pushing for an answer. You mentioned your husband. Seems like he was there with you at the time you were dealing with your PAD diagnosis and care. So what role as a family member did he play in helping you navigate that process?
When we got married, we were 52. We thought we were healthy, and we were ready to go do all the exciting things you want to do. And it ended up, having the diagnosis, and the surgery was a major ordeal.
Right.
The recovery from that surgery is really something else. And at that time, they didn't offer any kind of rehabilitation for that kind of bypass. So all of that fell to my husband. And, he rehabbed me. And he is involved in all of my advocacy. He's been there all of the way.
What a great support system, and I think the role of caregivers, as you said, it's just not talked about enough. And I want to recognize your husband and thank him for how much he helped you in this process.
Yeah.
So let me move on to my last couple of questions. And I also want to bring back Elvis into this. This question is for both of you. So Elvis, I'll begin with you. Hindsight, of course, is 2020. But when you think back to your journey and the opportunities for prevention on not just your end, but also when dealing with your healthcare providers, how would you have changed things?
Well, first thing I would be a little bit more persistent with the doctors and making sure they understand my plight and what can they do to help it. Uh, Also, I'll make sure now, like I do, and I express to people now that your heart tells you you have a problem. You chose to ignore it. The problem is you have to stop ignoring the problem
Right.
and be proactive and find out what's going on, because that's what we tend to do. We go to the doctor. We say, well, I'll go tomorrow, and then tomorrow becomes tomorrow. And
Right.
now I know better. Now, when I have a problem or it seems to be more severe, then I react and go to the doctor immediately. And that's what I would tell everyone. If you have a problem, don't be afraid to go to the doctor or take the time out to go to the doctor.
Thank you. Elizabeth, what would you have done differently?
Well, as I think that if I had to change anything, the number one thing would be I would have never put a cigarette in my mouth at 18. And
Right.
I think I would have, taken my family history more seriously and wish that somebody had talked to me about that.
Right. And you both kind of answered this in one way or another, but my final question for you, this is more towards people who may be newly diagnosed with PAD or are trying to navigate it right now. What is your advice to those people? Elizabeth, I'll begin with you, and then I'll end with Elvis.
Well, number one, I would say if you smoke, you need to stop. You need to make that your priority because you will never get well with cardiovascular disease if you smoke. Once you get that diagnosis, surround yourself with doctors that will teach you about your disease and, openly discuss things with you. And, like Elvis said, you need a doctor that's maybe not necessarily your friend, but that you feel comfortable
Right.
advocating for yourself. And if you
Right.
don't have that kind of doctor, I think you need to get a new one. But other than that, I would say, take all those lifestyle changes seriously.
Thank you, Elizabeth. Elvis, any final piece of advice?
Yeah, my advice is to stay active. Just because we get up in age or settle doesn't mean we have to stop moving. And if you're moving and exercising and walking, then if there's a problem, it will show itself. And then you can take care of it or seek advice or what have you. But to keep moving, stay active.
Absolutely. Well, thank you both so much, Elvis and Elizabeth. We appreciate your time.
Thank you for having me.
I want to thank Elvis and Elizabeth again. It's always important to highlight the patient perspective, but now let's get into the policy perspective. I'm thrilled to welcome U.S. Representative Donald Payne Jr. from New Jersey's 10th District. He's a strong supporter of national efforts to reduce PAD-related amputations, and he co-founded the PAD caucus in April of 2019 with U.S. Representative Gus Bilirakis. Representative Payne, welcome. We are so happy to have you.
Good afternoon, and it's an honor to be here with you today.
So we just heard from Elizabeth and Elvis. Both of them should have been diagnosed with PAD much earlier in life, but unfortunately they weren't, as we just heard. We know that this is due to significant awareness gaps, both in the general public and among providers who are responsible for identifying PAD. So do you hear similar experiences and concerns from folks back home?
I do, and it is, as Elvis and Elizabeth mentioned, I do hear similar stories actually from my constituents and people nationwide. The symptoms of PAD are close to those of other ailments. So doctors don't diagnose PAD unless they're looking for it directly. So it's really an issue of training and awareness. And right now, Medicare and Medicaid benefits will not cover vascular screening to detect PAD in patients. These screenings are the only way to find PAD and save limbs from an unnecessary amputation. For many PAD patients, the first warning sign is a pain in the extremities or a wound that will not heal. And if doctors do not know about PAD, they could make a wrong diagnosis of those symptoms and recommend medicines and treatments that fail to address PAD. Then the pains or wounds get worse until an amputation is the only option. And that is why I work to increase the awareness and funding of PAD in Congress. We must educate medical professionals about PAD so they can diagnose it correctly and save limbs.
Absolutely, thank you. So let's talk about the PAD caucus. I'm really interested to hear about it. What are the group's successes thus far?
Well, I created the PAD caucus to increase awareness of the disease and get more federal funds for their efforts to prevent it. You know, each member of Congress represents 700,000 people. And so if I can spread the word throughout the nation, every time I get a member of Congress to be aware of this issue, that is a person that can echo what we need to get out there in terms of information to 700,000 people. So, you know, it's not a disease that gets much attention, but I've been fortunate to have some early successes through the caucus already. I introduced the Amputation Reduction and Compassion Act, or ARC, in Congress to combat PAD. The bill requires Medicare and Medicaid and group health insurance to cover preventive screenings for PAD in patients with high risk of getting it. It establishes a PAD education program at the Department of Health and Human Services, HHS, to help doctors become more aware of PAD symptoms. And it requires HHS to take steps to reduce the number of unnecessary amputations from PAD. In addition, I'm working with HHS to improve research funding and home exercise treatment programs for PAD. Then I would like also to see HHS make that information available to all medical practitioners.
Thank you. So final question for you. Later on in our panel, we will discuss recommendations proposed by the American Heart Association to drive down amputation rates 20% by the year 2030. So can you talk about how you translate good ideas into good policies? Specifically, how does the PAD caucus integrate recommendations from experts in the field into legislative action?
It is important to use the statistics to show people that amputations are a serious problem and needs a lot of attention. For example, my staff worked with the American Heart Association and other medical experts before we introduced the ARC Act. Right now, I'm working on a second bill for PAD, the Bipartisan Preventing Amputations Disparities Act. It would create and support a project at HHS to determine how artery scans influence health outcomes for patients that high risk for PAD. The project would help discover which populations are at risk for it, so we can increase vascular screenings in those groups and stop unnecessary amputations. And that project would be a great example for how our work with the medical community can make a difference for PAD patients today and in the future.
Payne, I know we had such a short time together, but thank you very, very much for giving us your time and sincerely for caring about PAD. We hope to continue working with you in the larger advocacy community to accomplish these goals together. Thank you so much.
Well, thank you so much for having me. And, to everyone watching, I have a great deal of interest in this. I am a diabetic and I suffer from high risk of amputation because of that. So although it's not PAD, it is still something that I became concerned about because of my own health issues and stumbled into this. And I am totally committed to eradicating the unnecessary amputations that we find in this country and helping our constituents and Americans be able to understand and try to keep healthy and stay away from the peripheral artery disease. So thank you.
We are so glad to have you in this fight together. To close this discussion, we have Doctors Joshua Beckman and Kuni Matsushita. Dr. Beckman is founder and director of the Vascular Medicine section at Vanderbilt University Medical Center. And Dr. Matsushita is Associate Professor of Epidemiology and Medicine at Johns Hopkins University. Doctors Beckman and Matsushita, we're at the final stage here. So glad to have you. You just heard a policymaker talk about how to turn good science into good policy. So now let's shift gears and talk about the science on the ground and what's actually happening in the real world. Just for some context, a lot of our audience members today are clinicians who make decisions on behalf of patients every day. So Dr. Beckman, I'll start with you. Even on vacation, you are more than happy to join us and talk about PAD. We really appreciate it. So to that end, take us through a typical PAD journey from the clinician's perspective. You have a patient, you see certain telltale signs. What is next from there?
So the patient generally comes into the office, and the conversation really begins with, how are you doing? The patient who, say, has a modest level of dysfunction when they walk requires diagnosis. And so that first begins with a physical examination, looking for pulses in the feet, and then if they're absent or diminished, referral for an ankle brachial index, as Elizabeth Beard mentioned earlier. Once diagnosed, there's a standard set of medical therapies that need to be applied. These would reduce heart attack, stroke, cardiovascular death, and can also reduce complications of the limb like amputation. From the doctor's perspective, our first goal is really to get them to be active again, as Elvis mentioned. We want them to start walking around. We want them to do activity. And then we want them to tell us if they develop a sore or worsening walking so that we can jump in and try and help with that problem before it becomes too serious and leads to some kind of inability to walk or, at worst, amputation.
Great. So tell us who exactly should be screened for PAD.
So I think the AHA-ACC guidelines say it best. I think anybody over the age of 65 has about a 1 in 10 risk of having peripheral artery disease. That may not sound like a big number, but compared to most screening studies, that's actually quite large. Most screening studies require the screening of hundreds, if not thousands of patients to make a big difference. The American Diabetes Association would add in patients with diabetes above the age of 50, or even above the age of 40 if they have other risk factors like smoking. I would add in cigarette smokers above the age of 50 as well. So I think that anybody in the Medicare population and anybody above the age of 50 with a history of cigarette smoking or diabetes are the patients that I would look for to screen.
Thank you. I'm going to move on to Dr. Matsushita. You co-authored a paper, as I mentioned earlier, that raised the call to action, time to get to our feet. And in that paper, it states that amputations caused by PAD decreased by almost half in 1990 and in 2000, but then spiked again by almost half 10 years later. Why is that?
The recent increase in
leg amputation is largely restricted to patients with diabetes. The reason behind this observation is not fully clear. However, this may be due to suboptimal management of diabetes. In fact, a recent report in the New England Journal of Medicine has shown that glucose and blood pressure control among patients with diabetes has gotten worse since 2010.
Thank you. Dr. Beckman, just kicking it back to you, the paper also details the importance of focusing on rural areas. PAD rates, especially amputation rates, are significantly higher as patients in rural areas have less access to high-quality vascular care. So how can we fill that gap at this moment?
I think there are several strategies, one of which is early diagnosis. As Representative Payne mentioned, I think the opportunity to screen people at higher risk will help find them earlier in their course. I also think that once patients present with symptoms, we should make sure they have access to exercise, the supervised exercise therapy programs and standard medications. But if someone develops a severe limb problem with a non-healing ulcer or pain at rest, then I think there needs to be some access to a vascular expert, and probably just the local medical institution, if it does not have one, is not adequate for the management of that problem.
Dr. Beckman, a question just came from the audience. What is the difference between PAD and SCAD?
So SCAD, because we like to abbreviate everything in medicine, is when you have a tear in an artery that commonly happens in younger people. It's most common it's in the coronaries, and it mimics a heart attack. And by that, I mean it tears the artery and causes a blockage in the heart attack all of a sudden. It seems to be associated with an inherited abnormality in the blood vessels. Peripheral artery disease, in contrast, is more like the accumulation of plaque over a lifetime, so that basically very little blood can flow down to bring blood down to the level of the feet. One is a blockage from buildup, the other is a tear.
Thank you, that's very clear. So let's talk about PAD awareness, the root of this issue. Not only does the general public lack awareness, but as we've said multiple times already today, providers themselves are not aware that their patients even have a history of PAD, which further increases treatment gaps. So Dr. Matsushita, is it not common practice for primary care providers to check their patients' limbs?
Unfortunately not. There is a misperception even among healthcare providers that peripheral artery disease, PAD, is not so important. The term peripheral in PAD may give the impression that PAD is not central. However, it's very important for healthcare providers to ask patients regarding their leg symptoms and check their feet. This is particularly important in patients at high risk of PAD. For example, patients with diabetes, current or former smokers, and older patients, as Dr. Beckman described. Actually, clinical guidelines recommend annual foot monitoring in patients with diabetes. However, the adherence to this recommendation is pretty low and should be improved.
Thank you. All of us in the advocacy community place great importance on the use of effective educational tools for patients. There are so many out there. So in your opinion and experience working with your patients, Dr. Beckman, what exactly is considered an effective tool? And before you answer this, I'm going to share an image that you actually shared with me a few weeks ago. So please put it up on the screen.
So for me, when I try and educate people about a problem, I really want them to be able to have a picture in their head, something that they can grasp onto and then use as a baseline to understand everything I discuss. The absolutely disgusting picture of what I'm showing you on the right here is a clogged drain pipe. That clogged drain pipe really looks almost exactly like what it looks like in a blood vessel that has a severe amount of atherosclerosis. The plaque can look like ricotta cheese, like that white plaque does, and you have a much, much smaller lumen for blood to flow down. And eventually, if it becomes severe enough, you can have a clogged drain pipe and no blood will flow. And it has to find small bypass channels to get blood flow down to the toes so that you can maintain some circulation. But that pipe and anything I can do to put a picture in someone's head is the way that I can get them to understand how I think about the problem and then buy into the idea of stabilizing that plaque, trying to get that plaque to regress a little bit, and making sure it doesn't go any further. All the things I do, I basically try and use pictures because I think pictures describe a problem in a way that really allows anybody to grasp onto the real meaning. And so that's how I do it.
Pictures are worth 1,000 words. I will never forget that picture. Thank you for sharing it. Dr. Matsushita, data today reveals that among Medicare beneficiaries with diabetes and PAD, there is a 4-fold difference in amputation risks in Black Americans. So what drives this disparity exactly?
This is certainly a complex issue, and many factors are likely to be involved. For example, the prevalence of these factors of PAD, such as diabetes, is higher in Blacks than in whites. And the access to care is also an issue. Other socioeconomic status factors, such as lower income and education, have been linked to an increased risk of PAD and leg amputations. Importantly, in a recent study using data from Veterans Health Administration, this racial disparity of leg amputation remains even after accounting for some measures of socioeconomic status, such as income. So we should try to better understand social determinants of health behind this racial disparity of leg amputations.
Thank you. I want to end this discussion with a question for you, Dr. Matsushita, and then I'll take it to the audience questions that have just been submitted. So, you guys wrote this call to action, published with the American Heart Association. So what are the key recommendations for achieving our national goal to reduce limb amputations 20% by 2030? And Dr. Matsushita, I will take an image directly from the AHA paper that you both published to help guide your answer.
Yeah, so actually there are many things that can be done better in terms of preventing, diagnosing, and treating PAD. So as shown in this figure from our policy paper, the key is collaboration across different stakeholders, such as policymakers, healthcare providers, healthcare organizations, and patients. I will not be able to go through all the elements we have put in our paper, but a few representative recommendations include consistent reimbursement of the diagnostic test of ankle brachial index, implementation of quality and performance measures for PAD care, and coverage for annual foot monitoring in patients with diabetes.
Okay, so just final question, and we talked about amputations, but we really didn't go directly into it. So this question, Dr. Beckman, is for you. Do you think patients are fully informed of the expected quality of life change post-amputation? I'm sure there are several downstream effects as a result of an amputation. So can you please just talk about that a little bit?
So I want to separate two different kinds of amputations. Sometimes a toe is amputated or the very front part of the foot is amputated as part of a goal to make sure that the rest of the leg can be saved. Those, in general, are beneficial because it prevents the much bigger amputation that I think your patients are the people are envisioning. If you have a below knee amputation, maybe half the people get to walk normally again. An above knee amputation, even fewer. What's really scary is that the patient with diabetes who has an amputation, they have a 1 in 2 chance over the next 5 years of having the same problem develop in their other leg. There's also the people who end up needing an amputation have a much higher risk of dying from heart attack and stroke over the next several years. It is a terrible marker, and it really begins to limit almost everything that you can do. This is not like when a soldier has a traumatic amputation from an explosion and learns how to walk well again on a prosthetic for their leg. It really gets to be a much, much more difficult thing. And we all work hard to try and get people to be able to walk around again, but the success rates are not high enough for anybody's expectations. It is something that you want to avoid like the plague because it's a bad marker for outcomes and it really can diminish your quality of life severely.
Thank you. Well, this concludes our panel. Thank you both so much. It has been a great discussion. So Ryan, we are at the finish line now. Where do we go from here?
Well, Jasmine, I think, to circle back to what Dr. Patel referenced at the start, we know the stakes are high. Cardiovascular disease continues to be the #1 killer of Americans, and the rates for disease continue to go up year after year. However, it was encouraging to hear from our panelists today that many tools already exist to address our cardiovascular epidemic. We know health systems are implementing protocols to improve guideline-based care. Legislation is moving to stop patients from being non-medically switched from the medications that are keeping them healthy. Part D reform is gaining some bipartisan support. And as you heard today, members of Congress are increasingly understand the importance of cardiovascular disease prevention.
Absolutely. And really something that Dr. Patel said earlier that resonated with me the most is that action happens when the public demands it. I know that we will continue to push for patient-centered reforms, and we look forward to partnering with our viewers to do the same.
Absolutely. And Jasmine, to that point, if you care about health policy and cardiovascular disease, join us. PATCH is a coalition of organizations that are working together for patient-centered reforms to our health system. And we are stronger with more input and more perspectives.
Well, that's it. Thanks to our amazing panelists, our colleagues, our sponsors, and especially thanks to all of you for joining us today. We will see you next year in person in Washington, D.C. Take care, everyone.
Be well.